So what's up, pharmates? Today we are going to talk about the pharmacology of anesthetics. So what are anesthetics? Anesthetics are drugs that is used to induce anesthesia. So defining anesthesia, anesthesia is a reversible condition that is induced by anesthetics that cause reduction or complete loss to pain or sensory to pain, or other sensations such as consciousness or muscle relaxation that is useful in surgical procedures or other invasive procedures that may cause pain. So, there are 4 stages of anesthetics, so let us talk about that. The first stage is the induction phase or the analgesia. This is where we cut the patient's ability to feel pain, or analgesia. The patient here is still conscious, and proceeding to the next phase, which is the phase 2, which is the excitement phase. In this phase, there's delirium, unstable respiratory rate, there's some increased respiratory or decreased respiratory rate, and increased blood pressure. Okay, and then for the third stage, we have the surgical anesthesia. Surgical anesthesia basically means that the patient is now ready for the surgery. In this phase, the patient's vital signs and others such respiratory rate, blood pressure is now stable. In this phase is very important to be maintained by other drugs to prevent overdose that could further lead to the next phase, which is the medullary depression or paralysis that could further lead to death. Okay, so it's been stated that the mechanism of action of anesthetics is unknown, but according to other studies, we could also assume that basically anesthetics work by inhibiting the person or patient's ability to feel pain, induce sedation. So we could assume that it works on the brain and the spinal cord. That is what the studies also show. So let's assume this is the brain, and here we have the spinal cord. Here we have the thalamus and reticular activating system. So the thalamus and reticular activating system is the responsible when anesthetics work on this area of the brain, there is a reversible loss of consciousness. Next, we have the amygdala, prefrontal cortex, and the hippocampus. And when the anesthetic drugs work on this part of the brain, there is it causes amnesia. So and then finally the spinal cord, when anesthetics work on this, it causes immobility because the spinal cord allows you to move and such, and also anesthesia. So there are 2 types of anesthetics. First we have here is the general and then local anesthetics. The general anesthetics affects the whole body. Example here are general surgery procedures. And for the local anesthetics, this only affects a specific part of the body or in a localized area. Example here are dental procedures. So first, let's talk about general anesthetics. I'm going to divide these drugs into 3 groups depending on which receptor they act. So for the first group, we have here is the etomidate, propofol, and the barbiturates. Barbiturates drugs include the thiopental and methotrexate. These are examples of IV anesthetics, meaning we inject them through the veins. So their effect on the etomidate, propofol, and the barbiturates, when they bind to specific areas in the GABA-A receptor, they prolong the opening of the calcium channels thereby suppress neuronal excitability and thus promote unconsciousness. So, since we are disrupting the homeostasis of the body, there are side effects. So for etomidate, the side effects of this is adrenal suppression, transient skeletal muscle movements, including myoclonus. And for propofol, they're widely used in the induction phase. So again guys, the first phase is used mainly in the induction phase or the first phase. Side effects of propofol include respiratory depression and hypotension. And for the third drug, barbiturates, the thiopentone methohexital, its side effects include apnea, cough, bronchospasm, and respiratory depression. So these are the drugs. And for the group 2, IV siya guys, IV. Group 2. Group 2 drugs targets the NMDA receptor or the N-methyl D-aspartate. NMDA receptor. So the drugs here include the first, ketamine, which is an IV anesthetic. IV. And we have nitrous oxide, xenon, and cyclopropane. These drugs are inhalational drugs. So let's talk about the mechanism of action of this. So the NMDA is located in the spinal cord, and it uses the glutamate neurotransmitter, which is known as the excitatory neurotransmitter again. When glutamate binds to the NMDA receptor, it causes inflow of extracellular calcium into the postsynaptic neuron, which then activates a sense of signaling molecules, causing the pain signal to increase. So the purpose of this ketamine, nitrous oxide, and these drugs, they inhibit the calcium channel, which reduces the ability to feel pain again. So proceeding to the third group, the halogenated volatile anesthetics. For the second group, it has been stated that it also consists of inhaled anesthetics, but those include the gas anesthetics. In the third group, this specifically includes the halogenated volatile anesthetics. But before proceeding to these drugs, I'd like to discuss this one term called MAC, which stands for minimum alveolar concentration. It is the concentration of an inhaled anesthetics in which at 1 atmospheric pressure prevents the skeletal movement of in response to surgical incision in 50% of patients. So we use MAC as usually to determine the potency of the drug. If we have high MAC, it means that the drug or the inhaled anesthetic has a lower potency. This is because we only need smaller concentration of the drug to give effect. Or the most potent inhaled anesthetic first we have is the methoxyflurane. High potency, this means lower MAC. The least is the nitrous oxide. Next to methoxyflurane is halothane. So most potent ang methoxyflurane. It also causes tachycardia and cardiac arrhythmias. And for halothane, this smells good, but it also is hepatotoxic, cardiotoxic, and causes malignant hyperthermia. There is a cure for malignant hyperthermia, which is dantrolene. Next one is enflurane. It is pungent, so it does not smell good and is not good for kids. So halothane smells good, so it is good for kids. It also causes, again, kidney damage, and because it releases fluoride, and is contraindicated in patients with seizures. Next drug we have is isoflurane. This is pungent, so again it is not good for kids, but it is good in kidney, liver, and the heart because it has less fluoride compared to enflurane. Next we have is desflurane. It is the most pungent. The best smelling one here is sevoflurane. It's good for kids, but it also causes several tachycardia or arrhythmia. Pero lesser siya compared to other things. So we have here nitrous oxide, again, the least potent and has the highest MAC. So this is also known as the laughing gas. So it is good for the liver and has a lesser effect on the heart. It has also no respiratory depression and again, the very least potent. But it can also cause hypoxia, leading to anemia, specifically megaloblastic anemia. And it also causes leukemia and abortion. So we also have this drug called dexmedetomidine, which is alpha 2 receptor agonist. So it inhibits the release of norepinephrine. So it has the unique ability to produce sedation and analgesia without the risk of respiratory depression. So proceeding to the next type of anesthetics is the local anesthetics. So local anesthetics is used to exert anesthesia in a specific part of the body or localized area, so it does not produce unconsciousness. It passes through the neuronal membrane and binds to specific receptor at the opening of the voltage-gated sodium channel, preventing sodium influx. So it also prevents the conduction of action potential, leading to loss of sensation in the area supplied by the nerve. Local anesthetics drug could be esters and amides. The least potent is the shortest acting. So here, first we have procaine, which has the potency of 1 and a short DOA. We have cocaine, has the potency of 2, and is medium acting. Third, we have here tetracaine, which has the potency of 16 and is long acting. And chloroprocaine, here na lang. Chloroprocaine, short acting, but together with epinephrine, it is medium acting. So last we have benzocaine. This is for surface area only. For amide drugs, we have 7 here. First drug we have mepivacaine. Second we have lidocaine, prilocaine. Fourth drug we have articaine. For dental anesthetics, 5 we have ropivacaine. So the birth of local anesthetics was on September 15, 1884, and cocaine was discovered to have a numbing effect on the cornea, but it causes addiction, so it is not used. Again, then the next discovery is the benzoic acid. It is hydrophobic, so there is still lacking. So for the next discovery, procaine was discovered, but the downside of this is that it has a shorter duration of action. So then tetracaine was discovered. It is a good drug, but it is toxic and limited to spinal anesthesia. So that's when the birth of lidocaine in 1948 happened, which has the most favorable duration of action and has less systemic toxicity. And it is also the most versatile and widely used anesthetic. But we need a drug that can prolong or block. So bupivacaine was discovered and introduced, which is more lipophilic, which can pass to BBB because it is more lipophilic and potent. But unfortunately, it has lethal effects on cardiac conduction and function. So the isomer is bupivacaine, and ang isomer niya is levobupivacaine and ropivacaine. Another here thing is local anesthetic plus bicarbonate can shorten the onset time of regional block, and a more lipid-soluble anesthetic is more potent and longer duration action, so it takes longer to take effect. If a vasoconstrictor is induced together with a local anesthetic, there is decreased blood flow and rate of systemic absorption. So the systemic toxicity of local anesthetics is blurry vision, lightheadedness, seizure, and cardiac arrhythmias.